Good morning, everybody. So I'm going to be talking about vasculitis in pregnancy this morning. I want to thank RheumNow for inviting me to speak today. These are my disclosures. So I wanted to start off by talking about resources that are available to both providers and patients and those who are interested in pregnancy and patients who are actively pregnant who have vasculitis. So VPreg was founded by Dr. Peter Merkel and Dr. Megan Close. It is a prospective online registry, but it also comes with a lot of really great resources. We have YouTube videos and printable handouts that can walk patients through what it would look like if they were pregnant, what decisions need to be made. And so it's nice to be able to point patients in a direction of a resource that they can access that has really good vetted information that's accurate. So this is what we're going to talk about today. I'm going to overview the literature, which is quite sparse and conflicting, and then we're going to talk about how to approach pregnancy and the topic of reproductive health with these patients, and we'll end with a few patient cases. So what we know is that patients with vasculitis who are interested in pregnancy, they feel very scared and isolated. I've spent the past year interviewing these women for a qualitative study, and they really want their rheumatologist involved in these conversations because they view us as the doctors who know them and their medications best. And we're the ones who are prescribing a lot of medications that are either teratogenic or have unknown safety profiles. So it is part of our responsibility as their physician in order to honor their reproductive goals and make sure that our therapeutic plans align with their personal goals. All right, so this is our first poll. So it's very simple. How many of you have discussed pregnancy with a patient with vasculitis, or maybe preconception counseling in a patient with vasculitis? Okay. So a good majority of you guys have discussed, which is phenomenal. In the prior data, it's shown that rheumatologists are less than half of the time engaging patients in these conversations. So it's really, really great that we have people who have been having these conversations, and then it looks like some people who have never had these conversations, which is also okay because we're going to talk about how you can work that into your clinic visit with them. So I created this table because I wanted to demonstrate a few different things. Oftentimes patients will come to me and say, what are the chances of this? Can you tell me what my chances are of developing preeclampsia or having a miscarriage? And the reality is that we have extremely limited data, retrospective studies, systematic reviews, single center, one country, not a diverse population. So it's very hard for us to generalize the outcomes of these studies to our patients. And as everyone in this room knows, vasculitis is so heterogeneous. So one patient with ILD is going to have different risk than a patient who has heart failure or pulmonary hypertension. So what I tell patients is there is data available. Sometimes they like to have the actual medical literature, so I will print them out an article for them to read. But the reality is look how wide-ranging the percentages are, and that's because the way that these studies define pregnancy outcomes and were those patients sick when they conceived? Were they diagnosed with vasculitis during pregnancy and not going into pregnancy with a known vasculitis diagnosis? That all makes a big difference in the outcomes of the pregnancy. So I try not to overwhelm them or make them anxious when it comes to the data because we really just do not know. So then the next question is, well, what are my risks of having a flare if I were to get pregnant? So the table shows the impact of vasculitis on pregnancy, but this is a bidirectional relationship. What is the impact of pregnancy on their vasculitis? And in women with inflammatory arthritis, when we see them in clinic, we have a tagline where we say 30% of women will get better, 30% will get worse, and 30% will stay the same. And so I kind of like to use that with my autoimmune patients because the data shows quite a range, but around 30 to 40% of patients are experiencing flares. Now, how did these studies define a flare? Was it worse sinusitis and GPA? Was it an ILD flare or progression? It's defined differently. So again, you have to take the type of vasculitis into account, how active their disease is when they conceived and during the pregnancy in order to give them better insight into their risks of flaring. And I find that patients are very receptive when I say, I've looked at the literature and I would like to interpret the literature in your clinical context. And they appreciate that because then I can make an informed decision and give them the tools to make an informed decision about moving forward with pregnancy. So the answer is, it's certainly possible that you can flare, but let's talk about steps we can take to minimize the chances of a flare and optimize your pregnancy outcomes. The best pregnancies are those that are planned during times of quiet disease on pregnancy compatible medications. That is the take-home point from today's talk. So what I encourage rheumatologists to do is at each clinic visit, ask, do you want to get pregnant in the next 12 months? We actually have this, our MAs will screen the patient with a survey when they walk in the door, so we don't even have to ask this question. But no matter what the answer is, it's something that we can address. So if you do want to get pregnant in the next year, let's talk about how we can optimize you, get you plugged in with the right doctors so that you can have the best experience possible. And if the answer is no, then what are we doing to actively prevent an unplanned pregnancy? Patients with unplanned pregnancy and lupus have worsening maternal depression, and they also can have worsening disease, and that can lead to worse pregnancy outcomes because an unhealthy mother can lead to an unhealthy pregnancy and more complications. So as their rheumatologists, we are focused on optimizing maternal health, and we all have the same goal. We want a good pregnancy outcome, and your role as the rheumatologist is monitoring disease activity and ensuring that you are plugged into that multidisciplinary team because you are the autoimmune expert. Maternal fetal medicine doctors are phenomenal and they are brilliant, but they are not autoimmune disease experts. You are. And no matter how good they are, they cannot replace that knowledge that you have. So my take-home point for rheumatologists is to engage in these conversations and to be present because your patients really appreciate it. The next question, if they do want to get pregnant, is how active is their disease? And oftentimes I have to show this to patients. In these conversations, and probably in a lot of conversations, you cannot just tell a patient something. You need to demonstrate to them and build a case on why you do or do not think pregnancy is the best decision at this time. So are they requiring glucocorticoids? Are they being hospitalized? Are they non-compliant with their medication for various reasons? And then the last question is, if they're interested in pregnancy and they were to get pregnant right now, are their medications safe in pregnancy? And we'll go through the different categories of safety profiles for our medications. So I like to create a checklist and when I see patients in clinic because it helps me to be comprehensive because these conversations, they can be emotionally charged. These patients feel that family planning is a big part of their self-esteem and it's a big personal goal. And they're always afraid that I'm going to shut down that conversation or I'm going to shut down their personal goals. So I try to create a checklist so that we can talk about the risks and benefits. And oftentimes I'll have patients that still move forward with pregnancy even if I've recommended against it for medical reasons. And I still stick with them through the pregnancy. And I say, I'm going to be here and we're going to troubleshoot and we're going to try to find solutions as we go along. And giving the patient a sense of control over their own reproductive health makes a big difference in the relationship with them. So confirming pregnancy goals and timeline, discussing their disease activity over the past year, documenting organ damage, and the last time this was assessed. And I have slides after this where I'll go through in depth each of these different checklist items. Reviewing medications. Does the patient have a history of blood clots or recurrent miscarriages? Do they meet APS criteria? Do they have Rho antibodies that can lead to neonatal lupus? And then discussing the role of aspirin as a preeclampsia prophylaxis. And last is referring them to the doctors that can manage them during pregnancy. I personally believe that all vasculitis patients should have a high-risk OB or maternal fetal medicine. And they may also need cardiac anesthesia, other subspecialists, so maybe cardiology, pulmonology, nephrology, just depending on what their end organ disease is. I tell them that they should let all their subspecialists know their pregnancy plans so that we can all give them input from our perspective. So looking at disease activity over the past 12 months, so I try to ask them, how much of glucocorticoids have we required over the past year? And the reason I ask that is because in pregnancy, we try to minimize glucocorticoid use because it can lead to preterm delivery. So the higher the doses of steroids for the longer period of time can lead to pregnancy complications and also indicates underlying uncontrolled disease activity that we could potentially optimize with pregnancy-compatible medications that don't pose those risks of preterm delivery. Are they being hospitalized? Are they having to have stents placed for stenoses? These are things that indicate that we need to do potentially a better job of disease control. Now, depending on the type of the disease, I will have a discussion with them about baseline imaging. So for my Takayasu patients, we'll talk about echoes or CTA to see if there's been any progression of aneurysms. And that's because I have to remind patients that pregnancy is not a benign condition. Patients who get pregnant seek medical care because pregnancy is a medical condition that does pose risk to the mother. So it's important for us to understand the physiologic shifts in pregnancy, the expansion of blood volume, the stress that it puts on the heart and the kidneys. And in patients who have chronic kidney disease or heart failure, pulmonary hypertension, those risks may outweigh the benefits of continuing with a pregnancy. So I'm always trying to assess disease activity at baseline as much as possible. And also, sometimes these tests can lose sensitivity and specificity in pregnancy. So inflammatory markers are no longer reliable. Pulmonary function testing can be affected by pregnancy as you progress through the trimesters. And also, we want to avoid CT imaging as much as possible in pregnant patients. I have done CTPEs in pregnant patients when we had a very high concern for PE, but that's after a risk-benefit discussion with radiology. So we try to avoid imaging as much as possible. So getting these at baseline is extremely helpful to stratify pregnancy risk. So if the disease is active in the last year, I would say, listen, the literature shows that we would like your disease to be quiet for 3 to 6 months on a pregnancy-compatible regimen before we consider conceiving. And the reason is because if your disease is quiet, we know that that regimen works for you, then we can continue it throughout pregnancy, and the risk of having a flare is much lower if we go into the pregnancy with well-controlled disease. There are some contraindications to pregnancy. I have had conversations with patients where I have said it's unsafe for us to continue with pregnancy, but again, not abandoning the patient. They can make their decisions and move forward. And what we do is we just plug in the subspecialist and we collaborate and we make sure that they have the best support possible. And like I said before, we also will have cardiac anesthesia and vascular surgery. I typically see the patients once a trimester at minimum. If they're very sick, then I will see them maybe every 6 weeks just to ensure that somebody is monitoring their disease activity. They may need to be hospitalized. So I do see them quite frequently, and I'm getting blood work and urine studies because sometimes preeclampsia can be difficult to tease out from our autoimmune diseases, like glomerulonephritis from ANCA vasculitis. So having a UPC that's trended over trimesters can give us a little bit more insight into whether there's a superimposed preeclampsia on top of active autoimmune disease. So this is my next polling question. So in pregnancies exposed to a teratogen, which of these medications has the highest birth defects and pregnancy loss? Jack, just to let you know, the timer's frozen up here, so just let me know when my time's up. Okay, great. Mycophenolate is the correct answer. Good job. Oftentimes, people think it's methotrexate, so great. I'm going to go over that a little bit later. So these are snippets from the handout from VPreg that we created to make it a little bit easier for patients to understand their medication safety profile. What I like to do is I print it out and I circle the medications that they're on so that they can see what's safe for them to use. So the dark green are the safest. These are strongly recommended, really good data. You can continue them. Certolizumab, our TNF inhibitor, that can be continued throughout all trimesters. But other TNF inhibitors, we typically will stop around 32 weeks of pregnancy to prevent placental transference and fetal exposure to the TNF inhibitor. I will say that in the inflammatory bowel disease data, some of our GI colleagues are continuing all TNF inhibitors throughout all trimesters because the risk of a bowel inflammation and perforation outweighs the risk of continuing the medication throughout all trimesters. So it's certainly a discussion to have with patients. I also do not switch my patients from TNF inhibitors to certolizumab from one TNF to another for pregnancy. If they're stable on their TNF inhibitor, I will keep them on that. Now, I have this yellow category, which is unknown, and we have a lot of new drugs that are really fantastic, but we don't have pregnancy safety data. Mother to Baby is a great resource where they collect information on accidental exposures in pregnancy, so I direct my patients there because that's really how we get good information. The boxed medications, I read this review of biologics in pregnancy that was published last year, and there's some animal model data that these medications that are boxed can cause fetal abnormalities or pregnancy loss, but those were in animal models with much higher doses than what we give our human patients. Now, as most of you correctly answered, so mycophenolate-containing medications have much higher birth defect rates than methotrexate does, and methotrexate is notorious for pregnancy loss and for fetal malformations, but mycophenolate kind of gets lost in that. And what we try to tell patients is accidental exposures can lead to up to a fourth of pregnancies having pretty devastating birth defects. There's an MREMS program where you can counsel the patients on how to properly use contraception when they're on teratogenic medications, because as you can imagine, this is quite emotionally and physically stressful for patients to experience an accidental exposure and then have to decide about next steps in the pregnancy. Like I said before, prednisone is safe in pregnancy, but we try to keep it below 10 milligrams of prednisone to avoid any poor pregnancy outcomes. And then hydroxychloroquine, we'll talk a little bit later about Rho positivity, is also safe. NSAIDs we like to avoid throughout all pregnancy. And then rituximab we'll talk a little bit later. I typically like to dose it around conception or during the first trimester to carry them through the pregnancy. If there's life or organ-threatening disease later in the pregnancy, then you can redose it. But just know that there's a higher risk for a transfer through the placenta at that time. So what if my patient is not on a pregnancy-compatible regimen, but they want to get pregnant? So I like to give patients a time frame, because sometimes they come to me and they're like, I want to get pregnant right now. And I recognize and I validate their goals, but then I tell them, listen, in order for us to really have a successful pregnancy, let's plan. So I tell them, give me 3 to 6 months to convert your regimen from pregnancy incompatible to compatible, and then I want to watch you for 3 months on this new regimen to make sure you do not flare. Because what we don't want to happen is you switch their meds, and then you say, okay, your pregnancy compatible medication regimen is ready, go ahead and try to conceive, and then they flare within the first few months of being on that new regimen. So it's definitely a waiting game to see if their disease responds well to this new regimen. And then for patients who are in that period of transition and are still on teratogenic medications, I highly recommend effective birth control, which is IUDs and subdermal implants. If they're on mycophenolate-containing medications and they don't want to do an IUD or a subdermal implant, highly recommend 2 forms of birth control, because oral contraceptives can interact with mycophenolate and make the oral contraceptives less effective, predisposing them to an unplanned pregnancy. So if they're on medications with insufficient information, you would stop the medications and transition them to a compatible regimen. And sometimes I have patients that just show up with an unplanned pregnancy, or they just call and say, hey, I'm pregnant, what are my next steps? So incompatible medications, you're going to transition them. If they're on contraindicated medications like methotrexate, you can give them high-dose folic acid and continue that throughout the entirety of the pregnancy. In patients on leflunomide, if you happen to have a patient on that, you can do a cholestyramine washout as well to decrease those serum levels of the leflunomide. But for methotrexate, you can do high-dose folic acid. Maternal fetal medicine may also do more dedicated anatomy scans and more frequent growth scans in your patients. So I always alert their MFM that there's been an accidental exposure. So to stratify other risks that could be potentially associated with autoimmune diseases, I check for a Rho and LAW antibody. Patients who are Rho positive certainly are high risk for neonatal lupus, and so they're put on Plaquenil. I start them at 400 milligrams through at least the 9 months during the pregnancy. And then if they have no other indication for Plaquenil, I will stop it. Or if they have another indication and maybe their weight-based dosing is below 400, I'll go back to their weight-based dosing. But for those 9 months, I do 400 milligrams of Plaquenil. They will get fetal echocardiograms every 2 weeks between weeks 17 and 27 of pregnancy. We're looking at the structure and the function and the heartbeat. If they happen to have any indication of first or second degree heart block, we can talk about steroids and IVIG. I'm also checking for APS serologies. Lupus anticoagulant certainly is the most predictive for poor pregnancy outcomes, but if they are high risk for blood clots and they have APS and they meet criteria for APS with serologies, then we may need to talk about anticoagulation. So obviously there's different criteria for thrombotic versus obstetric, but there's different levels of anticoagulation that we would recommend based off of thrombotic versus obstetric. So that is our next question. Not the dosing per se, but if you have a patient with any type of APS, what type of anticoagulation would you recommend? Oh, did it not go through? Okay, I don't think we have that polling question. That's okay. So the answer is yes, they would need to be anticoagulated. So the way that I like to remember obstetric versus thrombotic low molecular weight dose heparin or dosing is to do obstetric with prophylactic or pregnancy with prophylactic, and then thrombotic with therapeutic. So therapeutic is typically a mg per kg of low molecular weight heparin twice a day, whereas prophylactic would be like once daily dosing, 40 milligrams. So what patients need to understand is that Pregnancy is a hypercoagulable state, and in the immediate postpartum period, this is also very hypercoagulable. So in patients who have vasculitis, which prior data has shown that they are at increased risk for blood clots, that pregnancy may be a situation where that risk becomes quite high. And if they've had a prior DVT, or they have an anticardiolipin or a beta-2 glycoprotein or a LAC that's positive, we may need to talk about anticoagulation. I think some centers, the maternal fetal medicine will prescribe it. At Duke, we prescribe it as well. We're pretty comfortable with that. They can inject into their belly. That's a question I get all the time. Even throughout the third trimester, they can inject low molecular weight heparin into their belly, and the bruising is okay. I do baby aspirin, 81 milligrams at 12 weeks as a preeclampsia prophylaxis. Our European colleagues are now doing double that, and they're actually seeing potentially an added benefit of an even higher dose prophylactic aspirin. I wouldn't be surprised if we start moving our practice in that direction as well. So let's move on to cases. I tried to pick cases that were very, very difficult and not super straightforward because I think it's nice to see how other doctors navigate really difficult conversations and medical situations. So this was a woman in her early 30s, and she was referred to me for preconception counseling. She has Takayasu, had just had a subclavian stent placed probably 6 months before I met her. Also has Crohn's disease with an ileostomy and an elevated RVSP. So many things that were sending off red flags. She had persistent claudication that seemed to be getting worse, elevated inflammatory markers. We couldn't get a blood pressure on her right arm, and I couldn't feel a pulse either. So her current therapy was azathioprine, dosed at about 1.6 mg per kg, and then prednisone, which she has been on for the past decade. So that was also a huge red flag. I will say that in my research, I've noticed we underdose azathioprine quite frequently. So in pregnant patients, I like to do 2 mg per kg as long as there's no concern for side effects with toxicity. But this is a case where we potentially, if she was progressing, could have increased the azathioprine dose and also to try to get her off prednisone. So these are her Takayasu manifestations. These are just screenshots from my note. So you'll see that she has very extensive disease, including the renal arteries. Renal artery involvement can certainly be a poor prognostic indicator for pregnancy outcomes, especially as you progress through the pregnancy and has those volume shifts and there's poor blood flow to the kidneys. It can certainly set off issues with high blood pressure and preeclampsia. So extensive disease. And then the last imaging study I had was probably from a year ago. And while she has extensive disease, it was read as stable, and this is done outside of my medical center. So I was really concerned by her labs. Also, she had undetectable azathioprine levels. So I completely agree with the conversations from yesterday. I check drug levels on all of my patients, especially when we're prepping for pregnancy, because a lot of them are secretly really scared to take medicines and they don't want to tell you because they don't want to make you mad. So this is a really good conversation starter. Hey, your azathioprine levels are non-existent. Are you taking your medicines? Let's talk about that. And she says, sometimes I forget to take it. So this woman with extremely extensive disease is only being treated by 5 milligrams of prednisone. And I don't even know if she's taking that consistently. So I thought, I'm going to demonstrate to her my concerns with moving forward with pregnancy. So I got a CTA. And unfortunately, within 5 months, her mid-descending aorta had almost doubled in size. So I presented her case at an MFM conference, and they all were just completely pale as I was presenting this patient about moving forward with pregnancy. They were very, very concerned. So I called her and I said, listen, your aorta is getting bigger. There's a risk of rupture and dissection if you were to move forward with pregnancy. Let's talk about, you need to be admitted to your local hospital and get worked up. And then let's regroup after this and kind of touch base on where we're at. And so she agreed, and then I called back a month later, and she thankfully had decided on surrogacy. And it was a really good example because I tell women all the time, even if you carrying the baby is not the safest option, there are other ways that we can fulfill your reproductive health goals. And I recognize it's important to you, and I'm going to do my best to carry it out the way that you want it done. But in her case, she can still have those personal goals fulfilled, but not at the risk of her own personal health. So my second case is a patient who originally was diagnosed with PAN, and then the diagnosis was converted to DATA2 after she went to the NIH. So when she was 6, she had a temporal artery biopsy that showed PAN. She was treated with cyclophosphamide, and her PAN was characterized by a lot of microaneurysms in the abdominal vasculature. She also had GI involvement. And so she was treated with cyclophosphamide. She was in transition to mycophenolate-containing medications and did fine until 2011. She suffered multiple strokes. Now, very fortunately, she doesn't have any residual neurologic deficits from these strokes, but it called into question the diagnosis, and that's when she was sent to the NIH around this time and was then diagnosed with DATA2. So at this point, after they did cyclophosphamide, they transitioned her to infliximab and methotrexate. And then a few years later, she was transitioned from methotrexate to azathioprine in preparation for pregnancy. So her local rheumatologist did a great job. I met her when she was 17 weeks pregnant. So a lot of my ability to control outcomes was lost at that point, but still a lot that we can do to manage any flares that could occur. So she did not want to stop the infliximab, even at 32 weeks. She was super adamant, I don't want to stop it because I don't want to have more strokes. So it was a long conversation with her NIH providers about the risks and benefits. I mean, she was on 10 mg per kg every 6 weeks, but then the other side is that what if she has a stroke because we stopped the TNF inhibitor? So we decided to continue the TNF throughout the entire pregnancy, but we timed her delivery. We tried to time her delivery around her infusion date. So she would deliver at 37 weeks, and then she could stay on track with her infusions with as little exposure for the fetus as possible. We also had a long discussion about aspirin. So in antiplatelets, there's risk for spontaneous intracranial hemorrhage in DATA2 patients. So we didn't think that the benefit of a preeclampsia prophylaxis outweighed the risk of an intracranial hemorrhage in her case. So this is the only case I have not recommended a prophylactic aspirin in a patient. She thankfully was Rho and APS negative because we did not need any additional complications in her case. She had already had imaging within the last 12 months that was stable, but cardiac anesthesia or vascular anesthesia really wanted an MRA of her brain to look for microaneurysms because they didn't know if it would be safe for her to push in a vaginal delivery. So that's why these are things I did not think of, and so that's why it's nice to have other specialists involved. But she declined the MRA and said she just wanted a planned C-section. Now, unfortunately, at 35 and a half weeks, she developed severe preeclampsia and ended up having an induced vaginal delivery via forceps. I don't know why they did that versus a cesarean delivery. I couldn't tell from the notes. Her son went to the NICU, but was discharged, doing fabulous. I saw her in postpartum. She feels great. She's healing well. Her son is doing well. She's breastfeeding. One thing that I do tell patients, you can breastfeed on TNF inhibitors. A good rule of thumb is if a medication is safe in pregnancy, it's typically safe in breastfeeding. One thing I have come into contact is something called nipple Raynaud's. So I've had patients when they try to breastfeed, they literally have Raynaud's of their entire breast. Extremely painful. They cannot breastfeed because it's so uncomfortable. And that is hard on their self-esteem. Women are very hard on themselves about being able to successfully breastfeed. So I've had really good outcomes with calcium channel blockers and nipple Raynaud's. And you can also be higher risk for mastitis and abscesses. So sometimes we will stop immunosuppression or we will transition off of breastfeeding if they keep having recurrent infections. Rituximab, I try to dose early, and if there's life or organ-threatening disease in the second or third trimester, we will then redose. Please vaccinate your pregnant patients. My last thing is the RSV vaccine that just came out. We recommend to vaccinate in the third trimester because there is data that it can lead to preterm delivery if given during pregnancy. The alternative is that the newborn can be vaccinated after delivery. So last thing is that whenever a woman comes to me and they're already pregnant, I always ask them if they want to continue the pregnancy because they may not want to. And so there's this one study on more than 1,500 patients who underwent abortions, and none of them had a flare of their autoimmune disease. I don't know how many of these were vasculitis patients, but they were all patients with rheumatic diseases. So this is potentially a resource that patients will want access to. And if they have questions about their disease flaring, the data we have available shows that it does not cause flares. And that's all I have. Thank you.